الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Cytomegalovirus infection CMV by Professor Mahmoud Hani Suleiman. At the beginning, I would like to say the importance of this infection is that it can be prevented and its hazards can be prevented by some measures. Epidemiology of CMV. CMV is highly species specific and only human CMV infect humans and lead to disease. Virus is ubiquitous and CMV strains exhibit extensive genetic diversity. Transmission occurs by horizontally, vertically, organ or hematopoietic stem cell transplant. Horizontal transmission by direct person-to-person contact with virus-containing secretions. Vertically, from mother to infant before, during, or after birth, and via transfusion of blood, platelets, and white blood cells from infected donors. CMV can be also transmitted by organ or hematopoietic stem cell transplant. Infections have no seasonal predilection, so horizontal, vertical, blood transfusion and blood products, organ or hematopoietic stem cell transplant. So the preventive measures will act on these measures. Epidemiology continued. CMV persists after primary infection with intermittent virus shedding. Symptomatic infection can occur throughout lifetime of infected person, especially under conditions of immunosuppression. Reinfection with other strains of CMV occur in seropositive hosts, including pregnant women. Seroprevalence of CMV immunoglobulin IgG antibody in population determined by many factors, including age, geographic location, race or ethnicity, cultural and socioeconomic status, and child rearing practices. 3 periods in life when there is an increase of incidence of CMV acquisition: early childhood, adolescence, and childbearing years. These are the 3 periods where there is increase in incidence of CMV: early childhood, adolescence, and childbearing years. Epidemiology continued. 2 distinct cases. First, CMV seropositive recipients who receive transplants from seronegative donors are at greatest risk of disease when exposed to CMV after transplant, perhaps secondary to failure of transplanted graft to provide immunity to the recipient. Latent CMV may reactivate in immunosuppressed. The second one is latent CMV may reactivate in immunosuppressed individuals and result in disease if immunosuppression is severe. Vertical transmission of CMV to an infant occurs in one of the following times. First, in utero by transplacental passage of maternal blood-borne virus. Second, at birth by passage through an infected maternal genital tract. 3, postnatally by ingestion of CMV positive human milk or by transfusion between 0 0.5% and 1% of all live-born infants are infected in utero and excrete CMV at birth. Epidemiology continued. In utero, fetal infection can occur in women with no pre-existing CMV immunity. It is called maternal primary infection, or in women with pre-existing antibody to CMV named maternal non-primary infection, either by acquisition of a different viral strain during pregnancy or by reactivation of an existing maternal infection. Epidemiology continued. Congenital infection and associated sequelae occur irrespective of trimester of pregnancy when mother infected, but severe sequelae are associated with primary maternal infection. Severe sequelae are associated with primary maternal infection acquired during first half of gestation. Damaging fetal infection following non-primary maternal infection reported, and getting different viral strain during pregnancy in women with pre-existing CMV antibody can cause symptomatic congenital infection with sequelae. Thus, the definition of protective immunity in congenital CMV infection remains unclear. Epidemiology continued. Although disease can occur in previously uninfected infants receiving human milk containing CMV or from CMV infected mothers, most infants who acquire CMV from ingestion of human milk do not develop clinical illness or sequelae. Among infants who acquire infection from maternal cervical secretions or human milk, preterm infants born before 32 weeks gestation and with birth weight less than 1.5 kilogram are at greater risk of developing CMV disease than are full-term infants. The incubation period for horizontal transmission of CMV infections is highly variable. Infection usually manifests 3 to 12 weeks after blood transfusion and 1 to 4 months after organ transplantation. Etiology. Human CMV, also known as human herpes virus 5, is a member of herpes virus family, herpes viridae, beta herpes virus subfamily, beta herpes virini, and Cytomegalovirus genus. The viral genome contains double-stranded DNA and is the largest of the human herpes virus genomes. Clinical manifestations. Manifestations of CMV vary with age and immunocompetence of host. Asymptomatic infections are most common, especially in children. Infectious mononucleosis-like syndrome with prolonged fever and mild hepatitis occurring in absence of heterophil antibody production can occur in adolescents and adults. Clinical continued. End organ disease including pneumonia, colitis, retinitis, meningoencephalitis, or transverse myelitis, or CMV syndrome, which equals fever, thrombocytopenia, leukopenia, and mild hepatitis occur in immunocompromised hosts, including people receiving treatment for malignant neoplasm, people infected with HIV, and people receiving immunosuppressive treatment for solid organ or hematopoietic stem cell transplantation. Less commonly, patients' treatment with biologic response modifiers can exhibit CMV and organ disease as retinitis and hepatitis. Clinical continued. Congenital CMV infection has a spectrum clinically but usually not evident at birth. Asymptomatic congenital CMV infection. About 10% of infants with congenital CMV exhibit clinical at birth symptomatic congenital CMV with jaundice due to direct hyperbilirubinemia, petechiae due to thrombocytopenia, purpura, hepatosplenomegaly, microencephaly, intracerebral calcifications, sensorineural hearing loss, and retinitis. Developmental delays common among affected infants in later infancy and early childhood. Death due to congenital CMV occur in 3 to 10% of infants with clinical disease, or 0.3 to 1% of all infants with congenital CMV infection. Diagnostic tests. CMV isolated in conventional cell culture from urine, saliva, peripheral blood, leukocytes, human milk, semen, cervical secretions, and other tissues and body fluids. Recovery of virus from a target organ provides strong evidence that the disease is caused by CMV infection. Immunofluorescence antibody techniques for immediate early antigen provides result within 24 to 72 hours. Diagnostic test continued. PCR is useful. Detection of antigen CMV antigenemia in WBCs is used to detect infection. Treatment. Intravenous ganciclovir for induction and maintenance. Treatment of retinitis with acquired or recurrent CMV infection in immunocompromised adult patients, including HIV patients, and for prophylaxis and the treatment of CMV disease in adult transplant recipients. For prophylaxis in adult transplant recipients. Valganciclovir, which is oral of ganciclovir, for prevention of CMV disease in kidney, pancreas, or heart transplant recipient. Again, there is prophylaxis for those who have transplantation. Also, for prevention of CMV disease in pediatric kidney transplant patients 4 months and older, and for pediatric heart transplant patients 1 month and older. Also, these two drugs treat CMV of other sites, esophagus, colon, lungs. It is found in tablet and powder. The coming pictures for some cases of CMV. A 3-week-old boy with congenital cytomegalovirus infection with purple skin lesions and hepatosplenomegaly. A newborn with cytomegalovirus infection and hemorrhagic skin lesions on the back. Infant with lethal congenital cytomegalovirus disease with purple skin lesions and striking hepatosplenomegaly. Infant in image with lethal cytomegalovirus disease with radiographic changes in long bones of ostitis characterized by fine vertical metaphyseal striations. Neonate with congenital cytomegalovirus infection with purple skin lesions. Axial T2 weighted magnetic resonance image demonstrates periventricular germinolytic cyst, the arrows, these two arrows, Also note periventricular white matter hyperintensities that are representative of demyelination and gliosis. Several measures are useful for prevention of CMV infection in high-risk patients. It can be prevented in high-risk patients by these measures. Use of blood from seronegative donors or of blood that was frozen, thawed, and deglycerolized. Decrease rate of transfusion-associated transmission. Matching of organ bone marrow transplants by CMV serology. Matching of organ or bone marrow transplants by CMV serology, with exclusive use of organs from seronegative donors in seronegative recipients. Decreased rate of primary infection after transplant. CMV glycoprotein vaccine. This is experimental. CMV glycoprotein B vaccine decreased infections in placebo-controlled trial among CMV seronegative women. This outcome increased possibility that this experimental vaccine will decrease congenital infections, but further studies must validate this approach. Prevention continued. CMV immune or hyperimmune globulin reported 1. To decrease rates of CMV-associated syndromes of fungal or parasitic superinfections among seronegative renal transplant recipients. 2. To prevent congenital CMV infection in infants of women with primary infection during pregnancy. So this immune or hyperimmune globulin has two benefits. Prophylactic acyclovir or valacyclovir may decrease rates of CMV infection and disease in certain seronegative renal transplant recipients. So acyclovir and valacyclovir may be used for prophylaxis among renal transplant recipients. وفي النهاية أقول الحمد لله رب العالمين, و thank you for your good listening.